some that are more recreational in their use, and then some that are very over the counter, things like caffeine. So the folks who are presenting amphetamines, do you want to go ahead and just talk quickly about the structure?
Yeah, so unfortunately this slide got a little messed up, but I was just showing the chemical structure. If you can imagine a phenyl group next to the hydroxyl there, that's covered up by the second picture. So they all have that phenyl group and then 2 carbon chain and then an amine. Yeah, next slide. So for the mechanism of action, this I got from the Katzen book. So they alter the transporters of central nervous system amines. So these are the dopamine, serotonin, norepinephrine, and they actually increase the release of these. And especially with dopamine, that causes the feeling of euphoria. That's associated with the amphetamines. And this picture is from the Katzen book as well. And you can see class 3, that includes the amphetamines, and it's showing the increase of dopamine on these GABA neurons. And I'm not completely sure exactly what's going on in that first part of the ventral tegmental area. But
yeah, so they're showing, I think, these 2 different regions of the brain just because they're regions that are known to be pathways for addiction. And so I think they're showing the relationship between both the VTA, the ventral tegmental area, and the nucleus accumbens, again, because they do have pathways that entrain for addiction. And I think because you're talking about the class 3, I think that first region, the first part of the figure is showing that you have class 1 receptor or class 1 actions of different drugs of addiction, things like the opioids, THC, and GHB that are acting on GABA receptors and activating those receptors expressed on the cells in that particular region. And then their class 2, you have them interacting with the cells of both the GABA and the dopamine cells, again interacting with GABA receptors. And then class 3 kind of branches and interacts with both areas, both the ventral tegmental area and the nucleus accumbens. And so by blocking that transporter, you block the reuptake and the release of the different neurotransmitters that you outlined here. Sorry, Shannon, I didn't mean to overtalk you, but I'm just going to provide some like supplementary information kind of as we're going through these slides, if that's okay.
No, that's totally fine.
Okay. Yeah, so you can think of the amphetamines as almost being like, I keep saying the SSRI because I think we think of the SSRI as kind of being that prototypical reuptake inhibitor, and that's exactly what this does, is it's inhibiting the reuptake, therefore prolonging the time of neurotransmitter that is in the synapse, and it prolongs the activation of those receptors.
Sorry, that's me. So I kind of focused a little bit on ephedrine more than just like the broad amphetamines, but they're pretty much really similar in a lot of ways. So some of the physiological effects, it's a stimulant. So it basically, like you kind of went over it a little bit in the previous slide too. It causes that release of all those kind of uppers almost. And I guess people get some of these effects. I'm not going to read through all of them, but some specific ones that people use ephedrine for. People usually lose their appetite, so it can be used for weight loss. And then it's also used in preventing low blood pressure because it kind of raises that up a lot of times. So yeah.
Okay, I misunderstood what you meant by clinically use, but I did look up some of the stuff. But it's been used a lot in OTC cold medications, and that's when you get people, and then also that's where we get the problem of people trying to turn them into methamphetamines because it can be done through a pretty easy chemical process. And it's used to counter orthostatic hypotension during surgery, and it used to be used for weight loss. And this was also, the theory behind this was it was based on animal models. in which it caused the burning of brown fat. But since adult humans have such little brown fat, they thought it would still kind of work on just normal fat. And it used to be in a lot of weight loss supplements, but that's been taken off the market. And ephedrine, I think, has mostly been replaced by pseudoephedrine in a lot of OTC cold products as well. But for the PK parameters, it is minimally hepatically metabolized. It's mostly excreted in the urine, and it's got a half-life of about 3 to 6 hours, depending on urinary pH. So next. So I mostly, since recreational use of ephedrine isn't really a big thing, but it is, but methamphetamines is. I talked mostly about that. People take it to get a stimulatory effect and to get quotes unquote high. And then some people still get the weight loss supplements, like bodybuilders use it a lot to lose extra fat before like showtime. And so you still get a lot of people doing that, but yeah.
And then for negative side effects, there's lots of like, obviously CNS effects. People get dizziness, headache, dry mouth, blurred vision. And then that loss of appetite can be either good or bad, depending on what you're looking for. And then GI problems, nausea, vomiting, stomach pain, and diarrhea. And then people get the fast or slow heartbeat feeling where like they can really feel their heartbeat and they can hear like a pounding in their ears. And then just general nervousness, stuff like that.
Yeah. We talk about, so you guys focus primarily on ephedrine. We're talking about methamphetamine. Some of the negative side effects would be decreased neurological function, the eating away of enamel of the teeth. So you think of people who have, I guess it's more commonly known as like meth mouth, but you see the loss of that enamel and the breakdown of their teeth. They prematurely age, and the loss of like essentially collagen elasticity in their faces as well. So that can be part of the side effects for methamphetamine. There's also some long-term neurological deficits that can be actually observed via scans, which is going to be part of the presentation that I post online as well. Any tolerance, dependence, or withdrawal that you guys are able to note?
Well, for pseudoephedrine, I found that it doesn't really produce rebound congestion, but that's about all I found as far as that.
Okay. Yeah, methamphetamine is going to be fairly highly addictive, and again, this will be something I discuss a little bit more in the presentation that I share with y'all. Okay, so moving on to group 2 on cocaine.
So this was one of the ester type drugs that we had talked about when we talked about local anesthetics. So then we just have a little note about the metabolism down here. And I guess the one thing about the esters is that they are metabolized kind of more quickly as opposed to an amide local anesthetic. So I guess that's one key part of the structure.
Yeah, definitely worth noting, especially when we talk about the PK and how that's broken down.
Yeah, and so then the mechanism of action, like with other stimulants, is just inhibiting uptake of the neurotransmitters that you see here. And then, as we've talked about before, also blocking sodium channels to alter signaling in local areas.
Oh, sorry. It also, in the physiological effects, it increases dopamine, noradrenaline, and serotonin by blocking DAT. So basically, those neurotransmitters will be in the synaptic cleft longer and will ultimately lead to the rewarding sensation that cocaine seems to cause for those individuals using it. And it activates the sympathetic nervous system in addition. So it also blocks the NET transporter, and that will cause the arterial pressure, tachycardia, and ventricular arrhythmias. So you're just going to have the actual, the peripheral stimulation. And that I just kind of had put in the physiological effects at the first part, which would be more of the clinical use. So sorry, Taylor. But I just had mentioned that, yeah, it was used to dilate pupils and treat depression and alcohol dependence. But Taylor will speak more on that.
Yeah, I think when I was asking about physiological effects, I think you did a good job here of kind of expressing both the central and peripheral effects of cocaine.
All right. So for clinical use, because of its properties as a anesthetic and a vasoconstricting drug, it can be used during procedures, and this can be especially helpful in upper respiratory tract procedures because it can also shrink the mucosa in the mucosal tract. And so, in the upper respiratory tract, these would be areas including the mouth, the nose, and the throat. And so, this cocaine can be used topically and applied before the procedures. And these procedures would include wound cleaning, getting a biopsy, or stitches. And I forgot to put in here, but it can also be used to stop nosebleeds.
Interesting.
For the recreational use, I took this right out of the Goodman-Gilman book. It just is kind of the side effects for the short term is increased heart rate, blood pressure, arousal, improved performance on tasks, alertness, sense of self-confidence. Higher doses produce euphoria. Repeated doses may lead to involuntary motor activity, stereotype behavior, and paranoia, irritability, and increased risk of violence. The half-life of cocaine is 50 minutes, but inhalant users desire more cocaine after 10 to 30 minutes. And then the side effects, the short term is basically the same effects that are kind of desired. But you can also experience tremors, vertigo, muscle twitches, paranoia. Long-term use, you can have intracranial hemorrhage, ischemic stroke, myocardial infarction, and seizures.
Yeah, so when we think of this as a stimulant, just too much stimulation can kind of tip you over into that seizure-genic area. Tolerance, dependence, and withdrawal.
This is also out of the Goodman-Gilman book. Because of the euphoric effect, it kind of makes it addictive for people. So it's harder for them to kind of get over that. And then also with more doses, they become desensitized to it and have to increase their dose because tolerance develops. But because it's intermittently used, there's go through frequent periods of withdrawal or crashes. So they need to gradually diminish symptoms over 1 to 3 weeks. And then they
Yes.
can also go through depression, and so sometimes they can be treated with an antidepressant.
Yeah, so you just can't just cold turkey. It's one of the reasons you're going to slowly taper off usage.
And that's actually the second point on this is
Hmm.
that the treatment is that they have an issue resisting the urge to resume use.
Nice. At one time was an ingredient in Coca-Cola. I'm going to keep moving just because in the interest of time. So focus on caffeine.
There's the structure, so it looks like adenosine. So it can bind to adenosine receptors in brain cells, and
Sorry.
Oh no, you're good. Most of caffeine stimulant effects are due to the way it acts on these receptors.
So it has a couple mechanisms of action that are listed here. So, yeah.
So even though it looks like adenosine, it antagonizes them?
Yes? This is what the good old Google said, so.
Okay. And then inhibition of phosphodiesterase, is that a result of the downstream activation of the adenosine receptors?
Yes.
Okay. Okay, in terms of physiological effects.
Cause the classic, I think everyone kind of knows how caffeine affects you. Jitters and anxiety, especially in higher doses. People with mental health issues can be more susceptible. and it can also aggravate symptoms of anxiety and panic disorder.
So caffeine is used therapeutically in combination with ergotamine for migraine headaches, and in combination with non-steroidal anti-inflammatory drugs and analgesic formulations. And caffeine alone is used as a somnolytic, which prevents sleep, to treat various headache conditions, respiratory depression in neonates, postprandial hypotension, and obesity, and to enhance seizure duration and electroconvulsive therapy. And then this is the recreational use chart I found. So coffee kind of tends to have the higher concentration per 100 milliliters.
This is a list of side effects that you can experience with caffeine, noting like anxiety, digestive issues, insomnia, things like that.
So obviously you can build up a tolerance to caffeine if you use it a lot. That's why people are out slugging whole pots of coffee to get pretty much the same effect as the 1 cup if you don't really drink a lot. And then it said that dependence can occur with greater than 100 milligrams per day, which is about 1 cup of coffee. So pretty easy to see. And then that's our notes on coffee.
Okay, so rather than rush through the folks who prepared the MDMA slides, please make sure that you attend class on Tuesday. I'll give you the first 5 to 7 minutes to kind of go over that part of the presentation, just because I am going to be carrying over lecture on Tuesday, and we'll be kind of talking, we'll be continuing our discussion essentially of many of these drugs and how the treatment of these drugs is essentially mediated. So I think it's a good transition point. Thank you all for everyone who stayed and participated today. I do appreciate it, even though we did change up the structure. So again, those folks who were part of the MDMA group, please do attend on Tuesday just so we can see your presentation, but I definitely don't want to rush over it right now during this time. Thank you all for your time today. Does anybody have any questions or concerns about the exam tomorrow or anything? If you don't, that's fine. I'm gonna go ahead and let you go. I'll be posting, you all have access to this on your Moodle page. I'll be recording and posting my lecture later today, and I'll be posting my presentation for this as well. So if you have any questions or concerns regarding that, please make sure that you reach out to me, and I'd be happy to answer those over the weekend.
Katie, I have a question.
Yes, of course.
So on caffeine, I had heard that like kids that have like a hard time focusing are told that they could try, like parents could try having them drink like a small cup of coffee in the morning to help them focus, because it helps something with like their frontal lobe. Is that something that you've heard or like?
I guess it's kind of that idea of using a stimulant to increase focus. So kind of the same way Ritalin is used, kind of that very similar mechanism of using a stimulant to increase focus in particular regions of the brain. So I think that might be kind of an anecdotal idea of using caffeine in that way. I think a much more over-the-counter prescription would be use of things like Ritalin. Does that make sense?
Yeah, that does. Perfect.
Yeah, and I'll just jump in there real quick. Stimulants activate the reticular activating system, which is a mechanism that the brain has for screening through incoming stimuli. And so that increases focus. So sometimes it seems a little bit backward, but a stimulant would be useful in that regard. But its ability to enhance reticular activating system function seems to be an important mechanism.
Gotcha. And do they just feel like it's probably more beneficial in kids because they're not exposed to caffeine as often as like adults, or does that also, like, is this also something that's like beneficial?
I think it works for adults too.
Yeah. Okay. Awesome. Thank you very much.